share with you, some thoughts and some findings this afternoon about breast cancer screening. Thank you, for being here for this third public health grand rounds, as Dr. Pack mentioned. The title of my presentation is Improving Breast Cancer Screening, Individual, Provider, and Social Factors. Okay, so I'm going to try to achieve, three objectives this afternoon. Present some very basic facts and figures about breast cancer. Briefly share methods and findings of my recent work in this area. Hopefully with some emphasis on how this research was developed over time, because this was one of the purposes of developing the grand rounds, is research development for faculty in the college, and then conclude by outlining next steps and future plans. Some basic breast cancer facts, which I'm sure many of us know. Breast cancer following skin cancer is the most frequently occurring cancer in women. So out of every 8 women, 1 woman will develop breast cancer at some point in her life. This means that over 200,000 new cases of breast cancer will be diagnosed this year in the U.S. In addition to those, there will be another 60,000 plus cases of in situ breast cancer that will be diagnosed this year. Oh, gosh. Okay, I'm sorry. Okay, and breast cancer is the third killer of women following heart disease, which is the #1 cause of death of women, and lung cancer, which ranks second. So this year, it's estimated that breast cancer will kill close to 40,000 women in the U.S. and over 500,000 women worldwide. Okay. Those supposed to get in there one at a time, but we'll forget about that. I'm going to ask you to play a quick, game here with me, a myth or fact game. So starting with the first one, I'm only 35. Breast cancer happens only in older women. Myth or fact?
Myth.
Myth. While the risk of breast cancer increases with age, breast cancer does occur in younger women and actually tends to be more aggressive in younger women. Most women who get breast cancer have a family history of the disease. Myth or fact?
Fact.
It's fact.
Fact.
Okay. While family history is a major risk factor for breast cancer, most women who get the disease actually do not have a family history of breast cancer. Okay, breast cancer can be easily prevented. Myth or fact? This is a myth. Breast cancer, there is no sure way today to prevent breast cancer, and that's why screening and early detection are the primary public health strategy to combat the disease. A mammogram every year would expose me to too much radiation, which would cause cancer. Myth or fact?
Myth.
This is a myth. The amount of radiation from mammography is very small. Mammography has been found to be safe, and its benefits far outweigh the minimal risks of radiation. And last one, breastfeeding can increase my risk of breast cancer. Myth or fact?
Myth.
This is a myth. Breastfeeding actually has been shown in many studies to have a protective effect against breast cancer. Thank you for playing this game with me. Let me see if I can play this. Okay, so some good news about cancer. Breast cancer death rates have been declining since 1990, in part due to advances in screening and in early detection, and in part due to improvements in treatment. And as a result, there are about 2.5 million breast cancer survivors in the U.S. today, many of whom have been cured from the disease. Early detection, screening have a huge impact on survival rates for breast cancer. What this slide shows is 5-year relative survival depending on the stage at diagnosis of the disease. So as you can see, in cases where the disease is diagnosed at an early stage, it's localized, the 5-year survival is almost 100%, and then it drops down to only 23% survival rate for distant stage disease. So this is to show again the impact of early detection on survival rates. Because of the benefit of screening, it is recommended that women 50 to 75 years of age receive a screening mammogram every 2 years. This is the current recommendation of the United States Preventive Services Task Force, which was issued in fall of last year. The USPSTF continued on to indicate that the decision to start mammography earlier, particularly in the 40s, should be an individual decision between the woman and her health care provider. The American Cancer Society, just as a note, continues to recommend the screening every year for women starting in their 40s, but this is the current USPSTF recommendation. Now, as I said, the good news is death rates have declined. We have effective screening methods, and we have effective treatments for the disease. The not so good news, however, is that screening rates, mammography rates, have not increased since the year 2000. So what we see here is a dramatic increase in mammography rates between 1987 and 2000, and then a plateau, a stabilization in mammography use this decade. So there really have been no gains in mammography rates since the year 2000. What is more disturbing than this plateauing of mammography rates are the disparities among population groups in screening rates and consequently in mortality rates. This slide shows mammography use by education level among women 40 plus in the US in 2008. The red bars represent the proportion of women who reported having had a mammogram within the past 2 years. The blue bars represent the proportion of women who reported a mammogram in the past year. Regardless of whether you look at the red bars or the blue bars, what you see here is a clear decrease in mammography rates as the years of education, as the level of educational attainment of the woman decreases. We observe a very similar trend with household income. As household income decreases, so do mammography rates. One of the most disturbing disparities, however, is between insured and uninsured women. In fact, women without health insurance have by far the lowest mammography screening rates, with only about 1/3 of them reporting a mammogram in the past 2 years. Now, those differences in screening rates do translate into differences in mortality from the disease. This slide examines breast cancer incidence and mortality by race, ethnicity in the U.S. For the 4-year period 2002 till 2006. The blue bars here represent incidence and new cases of the disease, and the red bars represent mortality rates from breast cancer. As you can see here, while white women are more likely, for example, than African American women to get breast cancer, they are more susceptible to the disease. African American women are significantly more likely to die from breast cancer compared to white women. In the state of Tennessee, specifically, the disparity in breast cancer death rates between white and African American women is even more pronounced. The overall death rate from breast cancer in the state of Tennessee is 26.4 per 100,000 based on 05 data. However, there is a huge gap between white and black women. Interestingly, and again, as we know, this overall death rate for the state of Tennessee is higher than the national average, which is true for other types of cancer as well. What this slide shows is cancer death rates in Tennessee relative to the U.S. Again, this is 2005 data. Here, the blue bars represent death rates for the state of Tennessee, and the green bars represent the national average. And again, whether you are looking at lung, prostate, breast, colorectal, etc., you see that the rates are worse, the death rates are worse in Tennessee compared to the national average. Those disparities, folks, in screening rates and the impact, on mortality and on public health, intrigued me to do work in this area. And as I started several years ago to think about developing a research program in this area, I was fortunate that back then at the University of Southern Mississippi, one of my senior colleagues, in collaboration with the University of Alabama at Birmingham, had obtained NIH funding to conduct, research and training in what they termed, as the Deep South region of the country. And part of their NIH grant, they issued a request for proposals for investigators to collect preliminary data, do pilot work in cancer control. I applied for that pilot funding, a mechanism which is similar to some extent to our RDC mechanism here at ETSU. I collected, some local data, and then I used that to apply for funding from the Susan G. Komen Breast Cancer Foundation to do a qualitative study, focus groups with African American women throughout the state of Tennessee in order to get some in-depth understanding of the barriers that they face in accessing screening services. And I used the behavioral model of healthcare utilization to guide, my research in this area. According to this model, we can predict use of healthcare services, including screening services, by predisposing, enabling, and need factors. Predisposing factors refer to age, educational level, knowledge, attitudes, and beliefs about the disease. Enabling factors refer to health insurance and household income that would enable an individual to receive or not to receive care. And need factors refer to perceived need and evaluated need by a healthcare provider. Very quickly, some of the key findings from the focus groups that we conducted showed limited awareness among women of risk factors for breast cancer. They showed, as we had expected, that regular mammography was not common, that screening was more common among women in their 50s relative to women in their 40s, and more common in urban relative to rural areas of the state. And we identified some of the key barriers that women face in accessing mammography services, including lack of awareness or education about the value of early detection, cost of care, particularly among uninsured women, fear of finding cancer, fatalistic attitudes. Many women believe that breast cancer is a death sentence, and if it's a death sentence, there's no need really to get screened or to find the disease at an early stage. Many women perceive the procedure to be very painful, and I remember, one of them, and I quote, describing the mammography procedure as flattening her breasts like a pancake. They also described, life pressures and poor transportation in rural areas as barriers to mammography. Those cross-cutting issues and themes were used to inform a statewide survey of women 40 plus. So again, this shows, the transition, the development of the research from the qualitative phase to the quantitative phase. This survey used computer-assisted telephone interviewing. It was a household survey. We screened those households in our sample for a woman 40 plus. We developed a questionnaire. It was validated. It was pilot tested with 30 women. And we collected a rich data set that has over 100 variables about factors pertaining to breast cancer screening. Key findings from this survey of 1,050 women. In terms of women's awareness of risk factors, we found that a majority of women were aware of family history and of hormone use as risk factors for breast cancer. Only half of the women knew that postmenopausal obesity increased their risk for breast cancer, and significantly fewer women, less than half, were aware, for example, that aging increases their risk of breast cancer, that alcohol use increases their risk for breast cancer. So significant, gaps in awareness of risk factors. We are developing, a manuscript now with Danny focused, on this. It's in its final stages of production, hopefully to be submitted next month. In terms of mammography rates, in our sample, again, of 1,050 women, the trends were consistent with the national data. So we found that African American women were significantly less likely to screen relative to white women. We found that mammography rates increased with educational attainment, and we found that mammography rates also increased with household income. So no surprises here. The good thing is that the sample is mirroring, is representative of what's happening elsewhere. We examined impact of access factors on mammography use, and again found that insured women were significantly more likely to get screened, and women with the usual source of health care, which is another measure of access also were significantly more likely to get screened. Consistent with the literature, we found that a doctor's recommendation for screening is a major factor that predicts whether or not the woman actually gets screened. Now, of course, after we identified, factors associated with screening at the bivariate level, we wanted to see what happens at the multivariate level, which ones proved to be, the most significant at the multivariate level. So we developed, logistic regression models to determine the association between mammography rates and predisposing, enabling, and need factors at the multivariate level. And interestingly, we found that all of the predisposing factors, the usual suspects, age of the woman, household income, even educational attainment, those dropped from the model and were in fact explained by access to care, by health insurance and having a usual source of care. And the key factor associated with screening at the multivariate level, the number one factor, was whether or not the woman had been recommended for screening by her provider. So women who reported that their doctor encouraged them to get screened were 6.6 times more likely to have had a mammogram in the past 2 years compared to women who reported that their doctor did not encourage them. Insured women were 3 times more likely to get screened relative to uninsured women. And again, that's after adjusting for all of the other characteristics. In this survey, we were also interested in measuring women's trust or mistrust of the healthcare system. This following up on the discussion that we had this morning with the doctoral students, this part of data we have just begun to examine. So, it is ripe for analysis. This table shows the percentages of women who agreed or strongly agreed with each of those dimensions of trust of the healthcare system, as well as perceived racism within the healthcare system. And again, in the interest of time, I won't go over each item separately, but as you can tell, significant proportions of the women mistrusted the healthcare system and perceived, racism within the system. And those are factors that we know from the scientific evidence are barriers to accessing, to seeking care, and to complying with screening guidelines. We also examined in this survey the prevalence of fatalism among women. Fatalism is the perception, that a disease is a death sentence, that we have no control over it. There's nothing that we as individuals can do to improve our chances of survival. Again, fatalism is a barrier to getting screening and getting a treatment. And we found overall that 1/3 of the women in our sample, 1 out of 3 women, believed that breast cancer is a death sentence and agreed with other measures of breast cancer fatalism. Okay, parallel, to this line of research, it became clear that we cannot really have a solid understanding of how breast cancer screening is delivered and how it's used without also understanding what's happening at the provider level. So to initiate, this research with primary care providers, we applied for funding, again from the Susan G. Komen Breast Cancer Foundation, to do a qualitative study with primary care providers in order to obtain in-depth information about their referral practices, their screening behaviors. And we conducted a series of 34 in-depth interviews with family physicians, internists, OBGYNs, and nurse practitioners. We identified major barriers to physician participation in screening and also to their participation in clinical trials. And we used those results to inform a regional survey which was conducted in 2007 in the central southeastern region of the U.S. That's the states of Alabama, Mississippi, Tennessee, and Kentucky, using a sampling frame provided by the American Academy of Family Physicians. The survey yielded 489 completed questionnaires, which for those of us who do surveys, with physicians is quite remarkable because they tend to be one of the hardest populations, to get to respond to surveys. Average age of the physicians was 51, 2/3 male. On average, they had been in medical practice for 23 years, and 43% indicated that they practiced in a rural area. And this pie chart shows their distribution in terms of their practice arrangement. So 30% were in solo practice, 10% in a two-person partnership, 43% in a family practice single specialty group, and 17% in a multi-specialty group. And I would just note this survey was limited to family physicians only, again because our research had identified that they are the primary care provider for women 40 years of age and older. We found that while a majority of physicians believed that mammography was very important for the early detection of breast cancer and recommended it consistent with guidelines, only 2/3 of the physicians reported referring the vast majority of their patients to mammography on a regular basis. So this is the physicians themselves, 1/3 of them reported that they do not refer 80 to 100% of their eligible patients for screening mammography. About 37% of the practices had a mammography reminder system, and only 2/3 of the physicians reported following up with patients who missed their scheduled mammogram. We asked them about the barriers that they face in referring women to screening mammography. 3 out of 4 physicians indicated that their patients do not regularly get annual checkups, and that this is a barrier to referring them to screening. About half of the physicians indicated patient refusal, patient preferences as a barrier to making referrals. 45% indicated that the patient sees multiple primary care providers, so they are counting on the other provider to deliver this care. And this is a classical example of the fragmentation of women's health care. A whole other grand rounds, if you dare bring me back. 37% of the physicians reported cost as a barrier to referring patients. And almost 1 out of 5 physicians indicated that they face time constraints in making mammography referrals. In conclusion then, we found that the relationship between patient and provider is a dynamic relationship. It is a two-way street. Among women in our studies, there were serious gaps in awareness of breast cancer screening guidelines, as well as awareness of breast cancer risk factors. Fatalism and other negative attitudes were common. Poor access hindered receipt of mammography, and a doctor's recommendation was the #1 driver of mammography. Among providers in our studies, we can conclude that overall they have positive attitudes about screening, and their recommendations fall within the guidelines overall. However, providers themselves face barriers in delivering screening, including the attitudes of their patients, the physician time constraints, and the overall lack of structural systems, office systems, to support the delivery of screening. In terms of the strengths of the research, it did investigate the problem of underuse of screening from the population and the provider perspectives, integrating both qualitative and quantitative methods, and examined screening using a comprehensive framework. However, those studies were limited in the fact that they were based primarily on cross-sectional data, so we can detect associations but not causal relationships. They were self-reported data, and although Dr. Hillhouse tells us that if you ask the question right, you get accurate data, there's still the possibility of some social bias in the responses. And what we also lacked was a multi-level approach to data collection and analysis. What this means is that we focused on the individual perspective, whether the individual is the woman or the physician, and we did not really account for the community context, for the neighborhood characteristics, which is something that we will correct for in our future research. So what does this future research looks like? We have proposed a large program project grant that was submitted to the NCI this past May, where we will be examining a 5-state, or to say that more accurately, we will be examining the Appalachian counties within a 5-state region. So the shaded areas here represent the study region. That's all Appalachian counties in Tennessee, Kentucky, West Virginia, Ohio, and Pennsylvania. We are proposing a comprehensive study of screening, treatment, and survivorship care in this Appalachian region, using a multi-level approach where community context and neighborhood characteristics are taken into consideration. And we believe, that this study region not only is significant because of the poor health indicators overall, but also it provides significant variation in terms of population density, poverty, and healthcare shortage areas, which are variables that we will need to examine the community context. So what you see on this map are the distribution of counties by economic status. The red counties are the distressed counties, and the blue counties are more transitional or competitive economically. There's also variation in population density and in whether the county is designated as a health professional shortage area, as a whole county, a partial county, or not at all. So again, this variation within this Appalachian region will allow us to examine the community context and to conduct a geospatial analysis of the impact of those variables on cancer screening, treatment, and survivorship care. And we are expanding the focus of research to include colorectal in addition to breast cancer. This map of the study region shows the distribution of counties in terms of the number of mammography centers that they have. So again, we will be looking at distance to providers, both primary care physicians, specialists, and screening facilities, as well as distance to treatment facilities to identify how those factors impact receipt of cancer care. And the counties that are in white here, they are not colored at all, are counties that have no mammography centers, 0 centers. The ones that are light gray have just 1 mammography center within the county. So this begins to speak to the shortages and the availability issues of healthcare within this Appalachian region that we plan to study. For this proposed research, we are expanding our models. So we are continuing to use the behavioral model of healthcare utilization to examine women's use of services, but we are adding the community context and proposing that it impacts predisposing, enabling, and need factors. And for our physician studies, we have developed a new framework based on the theory of planned behavior. This framework itself represents a contribution to the literature because there really is a lack of theoretical models to predict physician behavior. And here we are proposing that physician screening decisions are impacted by the proximal mediators of physician norms, self-efficacy, and attitudes, which in turn are impacted by the distal mediators of physician characteristics and patient characteristics, the patient-physician interactions, and perhaps for the first time in the literature, we are taking into consideration the practice characteristics and a broad definition of community context, and again proposing that those moderators impact both the proximal and the distal mediators, which in turn impact physician behavior. So again, that's in a nutshell what we proposed to the NCI in May, and we're hoping to hear soon about it. I will leave you with some breast cancer resources, and I will stop here and take any questions that you have.
Dr. Khoury?
Yes.
Some of the characteristics, of course, that in your new model, which looks very exciting and promising,
And complicated.
Well, that's how we start to simplify after we start with the complex. Health literacy, is that included in there as well, too? In this population, I would think that would be a significant factor, but is generally only recently being addressed.
Yes, thank you. That will be part of the community context here, Dr. Florence. So what some of the factors, some of the variables that we will be including here are, again, the usual suspects, neighborhood, socio-demographic characteristics, but we are really going beyond that to include distances to providers and health literacy as part of the community context. Yes?
One of the challenges from the first study was the difference in reporting between patients and physicians as to whether screening recommendations were really made or not. How will you correct for that in the larger study? Are you actually, other than reporting, you actually look at referrals as a written mechanism or what?
Yes, the nice thing about, I guess, a program project grant is we have submitted, 5 RO1s as part of that, and those RO1s will be able to share information. So specifically from this RO1 that's focused on women's behaviors, we will calculate aggregate measures of women's behaviors and use those as a contextual variable in the physician study and vice versa. So those will be accounted for, again, as part of the context. I perhaps didn't answer your question from the look on your face.
Well, you probably did, and I didn't understand it. The question, one of the questions is, are physicians recommending mammography or not? And the physicians say 64% of the time they're recommending it for 80 or 100% of women. And women are saying overwhelmingly they're not. It's the greatest predictive factor of not getting screened, at least in your first study. How will you know whether the actual recommendation is happening?
Okay, I understand now better the question. Actually, what we saw, the logistic regression, the data, they are showing that women who indicated that their doctor recommended screening were 6.6 times more likely to actually get screened. That, as you know, is very different from the percentage. Actually, in the survey, I believe about, and I do have those figures, somewhere around 70% of the women indicated that their physicians encouraged them to get screened, which is actually quite consistent with what the physicians told us. So we feel, confident in those findings. Other questions, thoughts, comments? Yes.
I have a question about community context. This is well-related parents, but are you planning on putting about social networks or